Hello friends, today will be discussing a very important topic, that is the anti-rheumatoid drugs. These anti-rheumatoid drugs except corticosteroid, all the anti-rheumatoid drugs basically suppress the rheumatoid process, and that suppression of the rheumatoid process brings about the remission and retard the disease progression of rheumatoid arthritis. Also, one more thing is that these anti-rheumatoid drugs has no non-specific anti-inflammatory or analgesic action. They are used, as we know, in rheumatoid arthritis in addition to the patient who are already taking NSAIDs, that is non-steroidal anti-inflammatory drugs. They are used in addition. They are also referred to as disease modifying anti-rheumatic drugs or DMARDs, or sometimes they are also called as the slow acting anti-rheumatic drugs, that is SARDs. The benefit with the use of these anti-rheumatic drugs is seen within a few months of regular treatment. However, if we stop the therapy with these anti-rheumatic drugs, the relapse is also seen within a few months. For resistant cases of rheumatoid arthritis, we use the biological agents in the form of antibodies or other proteins we use for resistant cases of rheumatoid arthritis. Now here we will talk about the rheumatoid arthritis. So what is rheumatoid arthritis? Rheumatoid arthritis is basically an autoimmune disease in which we see there is joint inflammation and there is synovial proliferation and destruction of the articular cartilage. And we know in rheumatoid arthritis there is production of immune complexes which are IgM activated complement. These immune complexes secretes lots of tumor necrosis factor alpha and interleukin 1, and these tumor necrosis factor alpha and interleukin 1 is chemoprotected for the neutrophils. Also, there is lot of inflammatory cells involved in rheumatoid arthritis that secretes lots of lysosomal enzymes. These lysosomal enzymes indirectly damages our cartilage and erodes the bone. Also, prostaglandin is also secreted in the process, and that leads to the vasodilation and pain in the joints. And we know that rheumatoid arthritis is a chronic progressive crippling disorder with waxing and waning course. For the treatment of rheumatoid arthritis, the first line drugs is the non-steroidal anti-inflammatory drugs. These are the first line drugs, and these drugs basically reduces the pain, swelling, morning stiffness, and immobility associated with rheumatoid arthritis. However, these non-steroidal anti-inflammatory drugs does not arrest the disease process. So what is the goal of the therapy of rheumatoid arthritis? The goal of therapy in rheumatoid arthritis is we have to reduce their pain, swelling and joint stiffness, prevent the articular cartilage damage and bony erosions, prevent the joint deformity, and we have to preserve the joint function also. For mild and early cases of rheumatoid arthritis, they are mostly treated previously with non-steroidal anti-inflammatory drugs only. But current recommendation is to add the DMARDs as soon as the diagnosis of rheumatoid arthritis is confirmed. For mild cases of rheumatoid arthritis, for using the DMARDs, we have to see the risk-benefit ratio, as the adverse drug reaction which are seen with these anti-rheumatoid drugs may be very serious, so we have to see their risk-benefit ratio before using DMARDs for mild cases. Currently, we use more than 2 DMARDs for rheumatoid arthritis. For advanced cases of rheumatoid arthritis, we have to add 2 or 3 drugs together. And as we know, the DMARDs lose effectiveness over time. Now we will see the classification of the anti-rheumatoid drugs. They are classified as DMARDs, that is the disease-modifying anti-rheumatic drugs, and adjuvant drugs. In the adjuvant drugs, we have the prednisolone and other drugs, and gold and penicillamine are also adjuvant drugs, but they are obsolete nowadays. And among the DMARDs are further classified as non-biological and biological agents. The biological agents are also include the tumor necrosis factor alpha inhibitors, that includes our etanercept, infliximab, and adalimumab, and interleukin 1 antagonist, that includes the anakinra. Among the non-biological agents, we have the immunosuppressants, that is includes the methotrexate, azathioprine, and cyclosporine. Also, sulfasalazine, chloroquine, hydroxychloroquine, and leflunomide are the non-biological agents we have. Let's first discuss about the non-biological agents. These include the immunosuppressants, that is our methotrexates. So, the methotrexate, the mechanism of action, it inhibits the dihydrofolate reductase enzyme, and it has prominent immunosuppressant and anti-inflammatory action. The beneficial effects in rheumatoid arthritis is due to inhibition of the cytokine production by methotrexate. It also inhibits the chemotaxis, and cell-mediated immune reactions are also inhibited by the methotrexate. When used in lower dose, it has improved acceptability, and the dose is 7.5 to 15 milligram weekly of methotrexate. Methotrexate has rapid symptomatic relief in patients of rheumatoid arthritis within 4 to 6 weeks. So it is preferred for initial treatment of rheumatoid arthritis. It is also the first choice drug or first choice DMARD, that is methotrexate is the first choice DMARD which we use. So it is the standard treatment for most cases of rheumatoid arthritis, that also includes the juvenile rheumatoid arthritis. The response with rheumatoid arthritis is more predictable and sustained over long-term use. Combination regimes which we use in rheumatoid arthritis of 2 to 3 drugs, that also includes our methotrexate. The oral bioavailability of methotrexate is variable, and that can be affected by the food also. In renal diseases, since it is excreted through renal route, it is not recommended to use in renal disease. Probenecid and aspirin increases the level of methotrexate in the blood, so we have to avoid using probenecid and aspirin with methotrexate. With trimethoprim, since trimethoprim also inhibit the dihydrofolate reductase, methotrexate also inhibit these enzymes that can depress the bone marrow, so we have to be careful in such cases. The side effects with low dose regime is oral ulceration and GIT upset. For prolonged therapy with methotrexate, there is risk of liver damage which can progress to cirrhosis. Methotrexate also increases the risk of chest infection. The contraindication with the use of methotrexate include pregnancy, breastfeeding, liver disease, active infection, leukopenia, and peptic ulcer disease. Let's continue our lecture of anti-rheumatoid drugs. This is part 2 of the lectures. We have already discussed the methotrexate, and now today we will discuss the azathioprine. This is another immunosuppressant. So when it is given to the patient, it goes inside the body and it is converted into the active metabolite known as 6-mercaptopurine, and this conversion is carried out by the enzyme known as thiopurine methyltransferase. Once the 6-mercaptopurine is formed, it causes the purine synthesis inhibition. It also causes the inhibition of the cell-mediated immunity and also alters the function of T cell and natural killer cells. And all this action of azathioprine leads to the suppression of inflammation in rheumatoid arthritis. Here I want to tell you that azathioprine causes remission only in small percentage of patients of rheumatoid arthritis. Also, it has the steroid sparing effect. When we cannot use the steroid or adverse drug reaction occurs with the steroid, so we add the azathioprine to the patient. So it has steroid sparing effect. It is usually not combined with methotrexate. The azathioprine is usually not combined with methotrexate, and the dose of azathioprine is 50 to 150 mg per day. So this was about the azathioprine. Cyclosporine we are not going to discuss here because it is very rarely used in rheumatoid arthritis. Now we will take another drug, that is the sulfasalazine. It is another non-biological immunosuppressant. So about the sulfasalazine, when it is given to the patient of rheumatoid arthritis, it goes inside the gut and it is activated by the bacteria, and it is converted into the sulfaparadine and 5-amino salicylic acid. This 5-amino salicylic acid has anti-inflammatory activity in the bowel. It acts locally in the bowel, and that's why it is useful in ulcerative colitis. Besides it, sulfasalazine is also converted into the sulfapyridine, and this sulfapyridine is absorbed in the circulation, and it causes the suppression of the production of superoxide radicals, and cytokine production is also suppressed, and this action is useful in rheumatoid arthritis. And the efficacy of sulfasalazine is modest, and in 10% cases with the use of sulfasalazine we have seen neutropenia and thrombocytopenia. Besides, it also causes the hepatitis, and it is also the second line drug for mild cases of rheumatoid arthritis. And this sulfasalazine is usually combined with methotrexate, and the dose is 1 to 3 gram per day, which is usually given in 2 to 3 divided doses. So after the sulfasalazine, another DMARD is the chloroquine and hydroxychloroquine. This drug causes remission only in 50% cases with rheumatoid arthritis, and this remission takes about 3 to 6 months, and it has relatively low toxicity when compared with other DMARDs. And I would like to tell here that bony erosions are not prevented with the use of chloroquine and hydroxychloroquine. Exact mechanism of action with the use of chloroquine and hydroxychloroquine is not known, but it has found to suppress the interleukin 1 level, thereby inhibiting the production of B lymphocytes. Other proposed mechanisms are antigen processing is interfered with the lysosomal stabilization, and free radical scavenging are the other proposed mechanism with the use of these drugs. For rheumatoid arthritis, these chloroquine and hydroxychloroquine is usually given for long periods of times, and that's why they accumulate in very tissues of the body, especially the melanin containing tissues. And the most disturbing effect is seen in the retina. It causes retinal damage and corneal opacities. However, this side effect is less seen with the use of hydroxychloroquine, and that's why hydroxychloroquine is preferred over chloroquine. Other adverse drug reactions which are seen with the use of chloroquine include rashes, graying of the hair, irritable bowel syndrome, myopathy, and neuropathy. These chloroquine and hydroxychloroquine are usually given for mild non-erosive disease when only few joints are involved in rheumatoid arthritis, and this is usually combined with methotrexate and sulfasalazine. The dose in case of chloroquine, it is 150 mg base per day. For hydroxychloroquine, it is given as 400 mg per day for 4 to 6 weeks, followed by 200 mg per day for the maintenance. Now another DMARD is leflunomide. Leflunomide is an immunomodulator, and it inhibits the proliferation of stimulatory lymphocytes inside the body. Thereby, it reduces the symptoms of arthritis, and also radiological progression which is seen in rheumatoid arthritis is also retarded with the use of leflunomide. The onset of benefit is very fast with leflunomide, that is, it is within 4 weeks the patient starts improving. And when we give leflunomide, it goes inside the body and converted into the active metabolite, which then inhibits the enzyme known as dihydroorotate dehydrogenase, and pyrimidine synthesis is inhibited in the actively dividing cells with the use of leflunomide. It also inhibits the production of antibodies from the B cells. The active metabolite in leflunomide has a half-life of 2 to 3 weeks. Therefore, it is given as a loading dose, which is 100 mg once daily dose for 3 days, followed by 20 mg once daily dose. And the adverse reaction which is seen with the use of leflunomide includes diarrhea, headache, nausea, rashes, loss of hair, thrombocytopenia, leukopenia. It also increases the incidence of chest infections and also increases the liver enzymes. It is not recommended to be used in children, pregnant women, and lactating mothers. Leflunomide is alternative to methotrexate. When combined with methotrexate, it leads to the hepatotoxicity. When it is combined with sulfasalazine, there is improved benefit is seen in rheumatoid arthritis. Another DMARD which are not used nowadays is gold. It is given as IM injection as gold sodium thiomalate. It has high toxicity. It causes hypertension, dermatitis, stomatitis. It damages the liver, kidney, and causes the bone marrow suppression. So it has gone out of use. Another gold compound is auranofin, which is less effective and less toxic, and it is being replaced by better drugs now. Now lastly, the D-penicillamine, it is a copper chelating agent. Its action and toxicity is almost similar to the gold, and it is no longer used nowadays. So let's continue our topic on anti-rheumatoid drugs. We have already discussed the methotrexate and the non-biologicals. So today we will discuss the biologicals, the biological DMARDs. The biological DMARDs, we have these are basically the monoclonal antibodies or the recombinant proteins or the tumor necrosis factor receptor proteins. So what these drugs do, they inhibit the cytokines which are mostly involved in autoimmune processes like tumor necrosis factor alpha and interleukin 1. So because they inhibit these cytokines, they are therefore beneficial in various autoimmune diseases like rheumatoid arthritis, inflammatory bowel disease, psoriasis and scleroderma. However, they do produce very prominent adverse effects and they are also very expensive. So therefore they are the reserved dose for severe and refractory cases of rheumatoid arthritis. So first drug is the tumor necrosis factor alpha inhibitors. So what these drugs do, they prevent the binding of tumor necrosis factor alpha with the tumor necrosis factor receptor 1, which are present on the T cell and the macrophages. And because the T cell and macrophages are unable to stimulated by the tumor necrosis factor alpha, so what happens, the further cascade of inflammation will not take place and therefore they are beneficial. So when this inflammation does not take place, therefore the inflammatory changes which occurs in the joints of rheumatoid arthritis patients and also the new regions which are being produced in the rheumatoid arthritis patient, they are decreased, they are slowed down, and they are very quick response than other non-biological DMARDs. They are usually added to the methotrexate when the response is not adequate with the methotrexate. They are also used in very rapidly progressive cases of the rheumatoid arthritis. However, these biological agents, that is the TNF alpha inhibitor, they do increase the risk of opportunistic infection like tuberculosis and pneumocystis pneumonia. Another drug is the etanercept. Etanercept is basically the fusion protein. So when this drug is given, they prevent the binding of tumor necrosis factor alpha with the tumor necrosis factor receptor. They basically do combine, they sit on the receptor, they do the fusion of the tumor necrosis factor alpha receptor with the Fc portion of the immunoglobulin G1. So when this binds here, the tumor necrosis factor alpha is unable to bind with the tumor necrosis factor receptor, and therefore the T cell is not stimulated and further inflammatory process stops. This etanercept is usually given as subcutaneous injection 50 mg weekly. However, they do report the side effects at these are usually the injection site pain, redness, itching and swelling. They also increase the incidence of chest infections. The dose of etanercept is 25 to 50 mg subcutaneously once or twice weekly. Another drug is infliximab. This drug is basically the chimeral monoclonal antibody that bind against the tumor necrosis factor alpha, and therefore the tumor necrosis factor alpha is unable to bind with the receptors on the T cells and macrophages, and further cascade of inflammation will not take place. The dose of infliximab is 3 to 5 mg per kg, and it is usually infused IV every 4 to 8 weeks. The side effects are usually the fever, chills, urticaria, bronchospasm, and rarely anaphylaxis. They also increase the risk of chest infections like tuberculosis and pneumonia. They also worsen the congestive cardiac failure. This infliximab is usually combined with the methotrexate. When combined with the methotrexate, there is improved response to the treatment, and further they also decrease the antibody production against the infliximab when combined with methotrexate. Another drug is adalimumab. This is recombinant monoclonal antibody against the tumor necrosis factor alpha. The dose of adalimumab is 40 mg subcutaneously every twice weekly. The side effect is the injection site reaction, and the incidence of chest infection is also increased. Similarly, when they combine with methotrexate, the response is there is improvement in the response, and also there is decreased production of antibody production. Another drug is interleukin 1 inhibitors. They basically inhibit the interleukin 1. These drugs, the drug in this group is anakinra. These drugs are less effective than tumor necrosis factor alpha inhibitors. They are usually used when more than one DMARDs fail. The doses of anakinra is 100 mg subcutaneously daily. The side effects are the local site reactions and chest infections. Other drugs include, we have the abatacept and rituximab. They basically inhibit the T cell and B cell respectively, and they are used for refractory cases of rheumatoid arthritis. Now we will talk about corticosteroids. These corticosteroids basically has very potent immunosuppressant and anti-inflammatory activity in rheumatoid arthritis. They can be used at any stage of rheumatoid arthritis along with first or second line drugs when we require a very potent anti-inflammatory action. They provide the very fast symptomatic relief. However, they do not arrest the rheumatoid process. However, with the corticosteroid, joint destruction slowed down and also the bone erosions are delayed. However, with the long-term use of corticosteroid, there can be very serious adverse effect as they can increase the blood pressure, they can cause the diabetes, they can cause the peptic ulcer disease, as we know. Therefore, when they are used either as low dose 5 to 10 mg of prednisolone, that usually supplement the non-steroidal anti-inflammatory drug. However, with this manner, the withdrawal becomes very difficult and the exacerbation can be precipitated and the patient usually becomes steroid dependent. Another method of administration is you can give the very high dose corticosteroid over a very short period of time until the DMARDs take their action. They are usually given at high doses over a short period of time when we suspect very severe manifestations like organ-threatening disease or vasculitis. For single or few joints involvement and with severe symptoms, we usually give the intra-articular injections every 4 to 6 months. In this manner, steroid offers relief for several weeks intra-articular injection, and joint damage is slowed down with intra-articular injections. So let's continue our topic on anti-rheumatoid drugs. Today we will be talking about the acute gout. So what happens in acute gout? Acute gout is basically a very severe and sudden inflammation that occurs in the small joints of the body. There is very severe inflammation in the small joints of the body in acute gout, and the most commonly involved joint is the first metatarsophalangeal joint. What happens in acute gout? There is deposition of uric acid crystal in the joint spaces, and the most commonly affected joint is the first metatarsophalangeal joint. And because of the deposition of this uric acid crystal, there occurs the formation of tophi in the joint spaces of patients of acute gout. And this uric acid crystal which gets deposited, it causes very severe pain in the joint, and the joint becomes very red, swollen and painful. And because of very pain and swelling in the joint, this condition requires very immediate treatment. And that's why we have various drugs to treat the acute gout. First, we will be talking about the non-steroidal anti-inflammatory drugs. As the name says, they have very strong anti-inflammatory action. So they are the non-steroidal anti-inflammatory drugs. And the drugs which include in non-steroidal anti-inflammatory, these include your naproxen, piroxicam, diclofenac, indomethacin, etoricoxib. So these are various non-steroidal anti-inflammatory drugs. As we know, they have very strong anti-inflammatory action, so they suppress the inflammation. However, you should be knowing they don't have any action on the uric acid production. They do not alter the level of uric acid, they only suppress the inflammation, and their action usually take 12 to 24 hours to take the effect. With regard to colchicine, colchicine acts quickly. Is colchicine another drug used in the gout? Colchicine acts quickly, but these non-steroidal anti-inflammatory drugs take 12 to 24 hours to start their action. As we know, they have no action on the uric acid level. You do not alter the uric acid level, and as we know, their action is slower than colchicine. As we know, these drugs has to be given for 3 to 4 weeks after the acute attack is over. When the acute attack of gout is over, we will continue to give these drugs for 3 to 4 weeks, because for 3 to 4 weeks, the other drugs which are actually controlling the uric acid level, their effect takes time. Until their effects take into account, their effects take place, we have to continue these drugs to suppress the inflammation. Once the other drugs which suppress the uric acid level, they take their effect, we have to remove these drugs. As we know, their long-term use is not recommended, because long-term use of these drugs can cause toxicity. Now another drug is colchicine. So colchicine is another drug which is used in acute gout. It is basically an alkaloid, and this alkaloid we derived it from colchicum autumnale. Colchicum autumnale, which was used in acute gout in 1763. It was used in since 1763, and it is an alkaloid which is derived from the colchicum autumnale. So this colchicine is neither an analgesic or not. It is an anti-inflammatory. It has no anti-inflammatory nor analgesic, but it does suppress the gouty inflammation. We will see how does it suppress the gouty inflammation. So we first understand how the mechanism of action in gout. What happens in gout? There is, as we know, there is a lot of uric acid being produced in the body, and this uric acid goes to the joint space. This is the joint space I have drawn. This is the joint space, and this uric acid in the joint space, we have these synovial cells. What they do, they engulf these uric acid crystals. Once these synovial cells engulf these uric acid crystals, they start producing lot of chemotactic factors. They produce lot of chemotactic factors, and these chemotactic factors start inviting your neutrophils, your leukocytes, and these neutrophils or the leukocytes goes in the joint space. And once these leukocytes goes in the joint space, what they do, these are the leukocytes, they start engulfing these uric acid crystals. These uric acid crystals being engulfed, as we show here, this being engulfed by these neutrophils. And once they engulf the uric acid, then they start producing glycoproteins. They produce lot of glycoproteins, and these glycoproteins then goes to your inflammatory cells. These are the inflammatory cells. We have monocyte, macrophage, fibroblast, all the inflammatory cells. These glycoproteins stimulate these inflammatory cells. They cause the production of lactic acid from these inflammatory cells. They also increase the production of lysosomal enzymes from these inflammatory cells. These are glycoproteins. And then this lactic acid and lysosomes, these lactic acid and lysosomes start going into the, they are in the joint space. They will destroy this joint. They will destroy the joint. They are going into the joint space, and as we know, they will act on this joint space. This lactic acid, as we know, the lactic acid will lower the pH in the joint space, and this lower pH will precipitate these uric acid crystals in the joint space, producing the lesion of tophi in the joint. Also, these lysosomal enzymes which are being released, they ultimately destroy the joint of patients of this gout. So here this was the how does the gout acts. Inflammation starts in the gouts. So what these colchicine do, they basically inhibit the release of these chemotactic factors from the synovial cells. Here does your colchicine acts. Also, they inhibit the migration of leukocyte into the joint space. They inhibit the migration of leukocyte into the joint space. Also, they inhibit the production of glycoprotein from these leukocytes. These glycoproteins are not being produced because of the action of colchicine. Then other uses of colchicine include because they act on the mitotic spindle and arrest the metaphase arrest. They cause the metaphase arrest. That's why they were used in cancer chemotherapy, but due to its toxicity, it is not used nowadays. So it causes the metaphase arrest. These are the other actions of colchicine. Also, it increases the gut motility, and therefore it can cause diarrhea as a side effect. So this was about the actions of colchicine. So let's continue our topic on anti-rheumatoid drugs. We are discussing colchicine. Today we will be talking about the pharmacokinetics of colchicine. So colchicine, as we know, is used in terminating the acute attack of gout. So when colchicine is given, it is very rapidly absorbed orally. As you can see here, the colchicine is absorbed orally. It goes into the gastrointestinal tract, from where it is absorbed and goes to the liver. In the liver, the colchicine is metabolized by the enzyme known as cytochrome P3A4, and it is then excreted into the bile. And when it comes into the intestine, the colchicine, the part of the colchicine goes in the feces, excreted in the feces, and the part of colchicine is reabsorbed back into the circulation. Here we can see the colchicine is again reabsorbed back into the circulation. Here again the colchicine goes into the liver, and the part is of the colchicine goes to the kidney. The part which comes into the liver, it is again excreted back into the bile, and this is known as antirhepatic circulation. So the colchicine goes antirhepatic circulation, and the part of the colchicine which goes to the kidney, it is excreted through urine. So the colchicine has excretion through kidney as well as through bile also. Also, colchicine binds to the intracellular protein called tubulin. Here we can see the colchicine binds to the protein tubulin intracellularly, and that's why it has very large volume of distribution. Because of large volume of distribution of the colchicine, so this drug colchicine undergoes very slow elimination from the body. As we know, it is metabolized by the enzyme cytochrome P3A4. So any drug which inhibits this enzyme is likely to precipitate the toxicity of colchicine. Now about the toxicity of colchicine, the toxicity of colchicine is very high and it is dose related. These include, it can cause nausea, vomiting in the abdomen, it can cause abdominal cramps, watery and bloody diarrhea, and all these adverse effects are dose limiting. Once you reduce the dose of colchicine, these effects come down. Whenever you overdose the patient with colchicine, it is likely to damage your kidney. It can cause kidney damage, central nervous system depression, even respiratory failure and muscular paralysis, and this can even lead to death of the patient when there is overdose of colchicine. Chronic therapy with colchicine can lead to aplastic anemia, agranulocytosis, myopathy and hair loss. So the chronic therapy with colchicine is not recommended. About the uses of colchicine, it is used for terminating the acute attack of gout and for prophylaxis, where we will prevent the acute attack of gout. For prevention of acute attack of gout, we will give colchicine at a dose of 0.5 mg to 1 mg per day. It will prevent the acute attack of gout. For terminating the acute attack of gout, we will give colchicine at a dose of 0.5 mg at an interval of 1 to 3 hourly. The maximum 3 doses we can give per day, and the maximum 6 mg dose we will give in 3 to 4 days. And it will control the acute attack within 4 to 12 hours, which is very rapid when compared with non-steroidal anti-inflammatory drug, which almost takes 12 to 24 hours to control the acute attack. For repeating the next course of colchicine, we have to wait for 3 to 7 days. After 3 to 7 days, we will repeat the next course of colchicine. We can also give the maintenance dose. We have to give the maintenance dose at a dose of 0.5 mg to 1 mg per day. We have to give maintenance dose for 4 to 8 weeks. Until then, the drugs which actually lower the uric acid levels, their action came into account. Only then we can stop the colchicine. So the brand name of colchicine is Goutenil. It comes in the form of 0.5 mg tablet. About the corticosteroids are also used in terminating the acute attack of gout. We will give soluble steroids intra-articularly to the patient at the joint space, where it will terminate the acute attack of gout. Crystalline steroids are not recommended for this action, and these intra-articular corticosteroids we will use only in refractory cases of gout, or those who are not able to tolerate your drugs like non-steroidal anti-inflammatory drug and colchicines. Only then we will give intra-articular injection to the patient. About the systemic steroid, these are also very highly effective drugs in terminating the acute attack. They are also very rapidly acting, and it is as rapid as colchicine. Their action is as rapid as colchicine, and these are the reserved drugs, and it is used only in those patients who are having renal failure or peptic ulcer disease, or those who are not able to tolerate non-steroidal anti-inflammatory drugs, or in those the NSAIDs are contraindicated. And systemic steroids like prednisolone is given 40 to 60 mg for a single day, followed by tapering over few weeks. So this is about systemic steroids in acute gout. So continue our topics on anti-rheumatoid drugs. Today we will be talking about the drugs which are used in chronic gout. So before we will discuss the drugs, first we will talk about what is chronic gout. What happens in chronic gout? There is, after the acute attack is over, there remains the persistent hyperuricemia, and that leads to the persistent pain and stiffness in the joint. And this persistent hyperuricemia then started depositing on the various tissues of the body that form this tophi on the skin. The sites of tophi include your joint. In the joint, there are formation of tophi around the pinna, there are formed the tophi around the eyelid, around the nose. Even in the skin, there is deposition of lot of urate crystal that forms the tophi. Also, because of the increased production of the uric acid and decreased excretion of the uric acid, there leads to the formation of urate stones in the kidney. So these all manifestations in the chronic gout, and because of the persistent hyperuricemia, persistent tophi formation and urate stone formation, this leads to the progressive disability and deformities at the joint in patient of chronic gout. So this is about chronic gout, and now we will be talking about the drugs that are used in chronic gout. So the drugs which are used in chronic gout, they are divided as the drugs which excrete the uric acid in the urine. That drugs are called uricosuric drugs, and there are certain drugs which inhibit the synthesis of uric acids, and that these are uric acid synthesis inhibitor drugs. The drugs which excrete the uric acid in the urine, these include your probenecid, sulfenpyrazone, benzbromarone. The benzbromarone is not used nowadays because of the potential hepatotoxicity of this drug. It is now withdrawn. Probenecid and sulfenpyrazone are used. Uric acid synthesis inhibitor include your allopurinol and febuxostat. Now first talk about the drug probenecid. This is a uricosuric drug as we talked about. This is probenecid. It is highly lipid soluble drug and it was initially used to prolong the action of penicillin. To prolong the duration of action of penicillin, it was used in 1951. What this drug does? This drug basically whatever the drug being excessively reabsorbed, it tries to excrete that drug through the kidney. And whatever the drug which is excessively excreted through the kidney, this drug tries to reabsorb that drug. For example, penicillin is most of the time is excreted by the kidney, so the probenecid try to reabsorb this drug. Similarly, uric acid when is more reabsorbed by the kidney, probenecid try to excrete it in the urine. So how does this probenecid do this action? It is basically stimulate one transporter known as the URAT1 transporter in the renal tubules, and by stimulating this transporter, it increases the excretion of uric acid in the urine and thus acting as uricosuric drug. So about the probenecid acid, it does not have any analgesic effect and anti-inflammatory action. It doesn't have any anti-inflammatory action and not analgesic action of probenecid. About the drug interaction, it has few interactions with many drugs. For example, it decreases the excretion of certain drugs. These drugs are scheme drugs, just to remember scheme. These include your sulfonamides, cephalosporins, endomethacin and methotrexates. So when giving these drugs with probenecid, their levels increases in the body. So we have to very cautiously while giving sulfonamide, cephalosporin, endomethacin, methotrexate with the probenecid. It also decreases the excretion of certain anti-tubercle drugs in the bile. These drugs are rifampicin, pyrazinamide, and ethambutol. So whenever you are giving these anti-tubercle drug with probenecid, their levels increases in the body and toxicity can occur. So you have to be cautiously use these drugs. It also decreases the nitrofurantoin level in the urine and thus not able to maintain the level of nitrofurantoin in the urine, and nitrofurantoin unable to perform its function in urinary tract infections. About the cell cyclates basically inhibit the action, uricosuric action of probenecid. So you have to be used cautiously with salicylate. About the pharmacokinetics of probenecid, it is 100% orally absorbed. It is 100% orally absorbed, and after absorption, it goes into the circulation where it is 90% bound to the plasma protein. It is 90% bound, and then it is conjugated by the liver and excreted by the kidney. About the half-life of probenecid is about 6 to 8 hours. About the adverse effects with probenecid, generally this drug is very well tolerated. However, the most common side effect noted is dyspepsia. You have to use it cautiously with peptic ulcer disease patients. Rash and hypersensitivity reactions are very rarely seen with this drug. At toxic doses, probenecid can cause convulsions and respiratory failure. About the use, as we know, it is used in chronic gout. Probenecid is used in chronic gout as a second line or as an adjuvant to allopurinol. It is used as second line or adjuvant to allopurinol. Usually it is started at a dose of 0.25 mg/BD, then this dose is gradually increased to 0.5 mg/BD. When used, probenecid decreases the blood urate levels, reduces the arthritis and tophi formation in chronic gout. Colchicine and NSAID has to be given with probenecid acid for the initial 1 to 2 months to avoid precipitate the attack of acute gout. So first we have to give the colchicine and NSAID cover for 1 to 2 months while giving probenecid. Probenecid and other uricosuric drugs are usually not effective in renal insufficiency when the creatinine levels is more than 2 mg per deciliter. So we have to keep this in mind. Also, because this probenecid causes the uric acid excretion in the kidney that leads to the formation of urate stones, so we have to give plenty of fluid when giving the probenecid. So we have to give plenty of fluid to the patient while using probenecid to avoid the urate crystallization in the urinary tract. Also, as we know, it prolongs the duration of action of penicillin and ampicillin, and this action is required when using this penicillin and ampicillin in conditions like gonorrhea and subacute bacterial endocarditis. Also, when we have to we combine probenecid with cidofovir when we are using it for cytomegalovirus retinitis in AIDS patient to prevent the toxicity of cidofovir, because cidofovir can cause nephrotoxicity. So we have to combine it with probenecid. Another uricosuric drug is sulfenpyrazone. Sulfenpyrazone is basically the uricosuric drug, and it has pyrazolone derivative, and it is related to phenylbutazone. Similar to probenecid, it has no analgesic or anti-inflammatory action. It basically inhibits the tubular reabsorption of uric acid. So uric acid is not reabsorbed and is excreted through urine in the kidney. So with smaller doses, it actually reduces the urate excretion similar to probenecid. So we have to increase the dose to increase the urate excretion through the kidney. It has equally efficacious to probenecid, but it is gone into disuse because of the potential gastric toxicity and other side effects of sulfenpyrazone. It is withdrawn in the United States of America, and another action, it inhibits the platelet aggregation also. So these drugs are uricosuric drugs. So friends, we will continue our topic on drugs which are used in chronic gout. We have already discussed the uricosuric drugs. Now we are discussing the uric acid synthesis inhibitors. The drugs in this group includes the allopurinol and febuxostat. First, we will be talking about the allopurinol. So before discussing the allopurinol, first we should know how does the uric acid form inside the body. So let's discuss the uric acid formation. So what happens? Normally, whenever the cell is broken down, there is a release of a lot of purines, like there is release of hypoxanthines and xanthines. These are basically the purines, and these purines are basically responsible for formation of uric acid. This hypoxanthine, when released by the cells, it is acted by the enzyme known as xanthine oxidase. This xanthine oxidase converts this hypoxanthine to xanthine, and when xanthine is formed, it is again acted by the enzyme xanthine oxidase, and it converts the xanthine to uric acid. In this way, uric acid is formed. So what we do, we will give the drugs which are of similarity with the hypoxanthines, like allopurinol. We give allopurinol to the patient. Now what does happen? This allopurinol goes and bind with this enzyme known as xanthine oxidase and inhibit this enzyme. And this enzyme, when it is inhibited, it is unable to convert the hypoxanthine to xanthine, and then again to xanthine to uric acid. So uric acid in this way is not formed with the use of allopurinol. But before, I would like to tell here, whenever we give allopurinol to the patient, it is again acted by the enzyme known as xanthine oxidase to convert this allopurinol, which is a half-life of 2 hours, to a more longer acting form known as the alloxanthine to alloxanthine. It is converted to alloxanthine when it is introduced inside the body, and it has a half-life of 24 hours. So alloxanthine is formed, and in this way allopurinol acts to convert or inhibit the xanthine oxidase and preventing the uric acid formation. About the pharmacokinetics of allopurinol, it is about 80% absorbed orally, and after absorption it goes to the circulation, but it does not bound to any plasma protein. It has no plasma protein binding. So that's why it is excreted unexchanged about 1/3, and rest of the form is excreted as alloxanthine in the urine. About the interaction with the use of allopurinol, it has an interaction with 6-mercaptopurine and azathioprine. Whenever we give allopurinol to this patient, they prevent the degradation of 6-mercaptopurine and azathioprine, as a result of which their level can increase in the blood. So we have to reduce their dose to prevent the toxicity of 6-mercaptopurine and azathioprine whenever we are giving allopurinol. Also, when allopurinol is added with probenecid shortens the life of alloxanthine. In return, allopurinol prolongs the half-life of probenecid whenever they are combined together. Also, there are certain drugs whose metabolism being inhibited by the allopurinol. These drugs include your warfarin and theophylline. Because they are not metabolized whenever their allopurinol is combined with them, so their toxicity can occur. The warfarin and theophylline toxicity can occur, so we have to be careful whenever we are combining it with allopurinol. Also, if the patient is already taking allopurinol, on the top of that, if we give patient the ampicillin group of drugs, then the incidence of rash increases with this combination. About the adverse drug reaction with allopurinol, although these adverse reactions are uncommon, but the most frequently noted is the hypersensitivity reaction, where the patient can have rash, fever, malaise, and muscle pains. And this incidence further increases if the patient is having renal insufficiency. Stevens-Johnson is a serious but rare side effects noted with the allopurinol, so you should keep this in mind, that Stevens-Johnson syndrome can occur with the use of allopurinol. Gastric irritation in the form of headache, nausea, dizziness are noted, but they are very infrequent. So that doesn't warrant to withdraw the drug allopurinol if these side effects are noted. Liver damage can occur, but it is very rare. About the precautions and contraindications, so whenever we are giving the allopurinol to the patient, we always advise to take plenty of fluid. So there is liberal fluid intake is advised with allopurinol. The use is contraindicated in pregnancy and lactation, and also we should be very cautiously using this drug in an elderly, in patients, in children, in patients with liver and kidney damage. We use it very cautiously. About the uses of allopurinol, it is the first choice drug in chronic gout. It is prescribed for both overproducers and under excretors of uric acid. It is prescribed in severe cases and in those cases where there is a lot of tophi formation and in patients with nephropathy. The long-term use with allopurinol reduces the incidence of tophi and nephropathy and even reverses the nephropathy. They are also prophylactically used in secondary hyperuricemia. Secondary hyperuricemia is seen with the cancer chemotherapy, with radiation exposure, and in those with thiazide diuretics. They are taking thiazide diuretics. The prophylactic use, we have to give prophylactically as a allopurinol to the patients. Also, as we know, they prevent the degradation of 6-mercaptopurine and azathioprine. So whenever we try to potentiate their action, we have to increase their action of these drugs. For example, in cancer chemotherapy, and whenever we want the immunosuppression action of these drugs, we always prescribe with allopurinol so that their level remain more in the blood and the desired action is achieved. About the dosage, it is termed as 100 mg once daily dose, and it is gradually increased after a week to 300 mg once daily dose, and the maximum dose we can give is 600 mg per day. It comes in the tablet form as tablet Xyloric as 100 mg and 300 mg tablet. About the cautions with allopurinol and other uricosuric drugs, they are not started in the acute attack of gout because it can even worsen the acute attack of gout. What does these drugs do? Whenever these drugs are given, they fluctuate the level of uric acid. That leads to the solubilization of the uric acid and again recrystallization of the uric acid crystals and can precipitate the acute attack of gout. So we have to be very careful to not give them in acute attack of gout. Whenever we are giving them, we have to give cover with non-steroidal anti-inflammatory drug and colchicine for the initial 1 to 2 months so that the acute attack does not precipitate with these drugs. It was also used for leishmania, Kala-Azar, but because of the poor efficacy, this drug is abundant nowadays for this action. Now, another uric acid synthesis inhibitor drug is the febuxostat. It is basically the non-purine xanthine oxidase inhibitor, and it has action almost similar to allopurinol. It is equally or more effective than allopurinol in reducing the incidence of gout, in reducing the uric acid level. It is very rapidly orally absorbed and it has a very high plasma protein binding, and whenever it goes to the liver it is oxidized and undergo glucuronide conjugation and later excreted by the kidney. And this febuxostat has a half-life of 6 hours. About the adverse drug reaction with the febuxostat, the most common being the liver damage, and you have to monitor liver function tests with the use of febuxostat. Other side effects are diarrhea, nausea, and headache. They are known to interact with drugs like 6-mercaptopurine, azathioprine, and theophylline. So, while prescribing these febuxostat with these patients, we have to be careful. About the uses of febuxostat, they are generally used as an alternative to the allopurinol whenever we are not able to give allopurinol due to contraindication with allopurinol, or the patient who are intolerant to the allopurinol, or the patient is having hypersensitivity with allopurinol. Only then we give the febuxostat to the patient. Also, febuxostat is not indicated for malignancy-associated hyperuricemia. Similarly, as with allopurinol, we also require here the cover of 1 to 2 months with non-steroidal anti-inflammatory drug and colchicine to prevent the acute precipitation of the gout. The dosage of febuxostat is 40 to 80 mg per day. Another new drug is the recombinant xanthine oxidase enzyme. It is the rasburicase. What this rasburicase do? It will oxidize this uric acid to a more soluble form, that is the allantoin, and then excreted in the urine. So uric acid level reduces with this drug rasburicase.